Today, I'll be talking about prevention, diagnosis, staging, and endoscopic treatment of colon cancer. We try not to teach to the test. We don't want to make this a board review exercise. However, I am going to try to highlight things for you that are likely to appear on your boards so that we can essentially make this a twofer. I do want this to be interactive. We can certainly do questions at the end, but feel free to ask questions during the talk as well. So let's start with a case presentation. This is a gentleman that came in about 3 weeks ago. He's a 51-year-old man who presented for colon cancer screening at an outside hospital. He was asymptomatic. He had no family history of colon cancer, and a mobile mass was found on endoscopy. So he was referred to us, and the mobile mass turned out to be a large mobile colonic polyp. It was about a 4-centimeter colon polyp with a very long stalk. We injected some epinephrine into it, snared it off, and happily, this was a completely excised, endoscopically excised carcinoma. He had adenocarcinoma, about 25% of the polyp. It was well differentiated. The tumor invaded the lamina propria and muscularis mucosa, but not into the submucosa. There was no lymphovascular invasion, and both the deep and mucosal margins were uninvolved. So this was an endoscopic cure, and is doing procedures like this is a lot of what we're going to talk about today. Why we go into gastroenterology. Colorectal cancer, just to give you some demographics to start. It's about 135,000 cases per year in the United States. Unfortunately, a little bit more than a third of those patients are going to die of their disease. It's the second leading cause of cancer death in the United States. And in many, if not most cases, it's preventable. Sadly, we're seeing this occur much more commonly in patients less than age 40, which has led to some changes in the screening guidelines and something we'll talk about towards the end of the discussion. So there are a number of different types of present. Sporadic colon cancer suggest a hereditary colon cancer syndrome, but beyond that, they don't have a single family member that had the disease or even an advanced adenoma. Familial colon cancer occurs when they don't have a defined disorders such as HNPCC, Lynch Syndrome, familial adenomatous polyposis, but they do have a family member, usually a first-degree relative with the cancer. And then a small percentage of patients, about 7%, have Lynch syndrome, have FAP, have Putz-Jaeger's or something like that we'll talk about. But the vast majority of cancers in the United States present as a sporadic presentation, sporadic cancer. So there are a whole host of genes that are responsible for both hereditary and sporadic cancers. And if you note, many of the genes, there's overlap between inherited germline mutations and somatic or acquired mutations that lead to colon cancer, particularly the adenomatous polyposis cancer gene and mismatch repair genes, which may be seen with a number of different cancers, particularly right-sided cancers. Sporadic cancers, again, you acquire these mutations throughout life. In hereditary cancers such as Lynch syndrome, FAP, these mutations are inherited. Most cancers proceed through one of two pathways. And the classic pathway that we've talked about for years is the adenoma to carcinoma sequence. And what's important to note is over a very long period of time, 10 to 15 years, normal epithelial tissue becomes hypertrophic and then develops dysplasia. And that's the moment that a small adenoma occurs. This small adenoma has about a 15% chance of turning into colon cancer over a period of, again, many years. But it requires subsequent mutations for it to do it, to become a large adenoma, and then to subsequently develop cancer. And the 10 to 15 years is an important number. It notes that it gives us a lot of lead time to get in there and identify these precancerous lesions, precursor lesions early, and excise them if we can get people to get colon cancer screening early enough, and also set the number, set the time of or first screening appropriately for their risk. During that adenoma to carcinoma sequence, there are a number of genetic mutations, mutational events that occur involving many of the genes that I showed you above. Some of these may be mismatch repair genes. KRAS mutations may spontaneously occur, somatically occur, followed by deleted and colon cancer mutations, loss of heterozygosity. But it's more than just the one mutation. It's more than just having a PMS1 or a PMS2 gene. You need to have multiple different mutational events that occur to take the polyp, for instance, an early polyp, to the next step of a large polyp, to the next step of a cancer. Also importantly, these may not occur in any specific order. Loss of heterozygosity may occur earlier in the course. Mismatch repair gene, genetic repair genes, or tumor suppressor genes may be deleted later in the course of the cancer. So this is the sequence of events that occurs, but this specific order of mutations may not in fact be the case. Again, this pertains to adenoma to carcinoma sequence. In addition to the traditional pathway, adenoma to carcinoma, there is a second pathway that almost certainly is involved in the genesis of a number of cancers, particularly those on the right side, and particularly those associated with mismatch repair genes, Lynch syndrome, and sessile serrated adenomas. In this pathway, microsatellite instability occurs, again, with a mismatch repair gene, most commonly MLH1, MSH2, PMS1, that allows alteration of the colonic mucosa such that there's hypermethylation, there's growth of a sessile serrated adenoma, a little bit of a variation on the standard adenoma, most commonly on the right side. And then again, accumulation of multiple different mutations may allow cancer to develop, usually not in a pedunculated polyp, but in a sessile depressed invasive polyp. And these folks may develop cancer through this separate pathway. Bottom line is both of these pathways lead to polyps. And we have two classic types of polyps. Traditional adenomas, which we've known about for years. They may be pedunculated on a stalk, as you see here. They may be sessile. These are sessile serrated adenomas, and very frequently subjectively, you can get a sense, well, this is probably a classic adenoma versus a sessile serrated adenoma by looking at them, but you don't know definitively without histology. But these are much more commonly going to be found on the right side of the colon. These are very commonly going to be associated with a mucus cap. Part of the reason why we have to do such careful colonoscopies, who I'll discuss with you later, is that we need to clean every little patch of mucus in the colon, because what could look like just a benign piece of mucus may actually be something that is generated by a sessile serrated adenoma, and unless we investigate it, we won't know. And that's why we emphasize colon preps as aggressively as we do. So that's sporadic colon cancers. Familial colon cancers occur, again, when somebody has a first-degree relative that has a cancer or an advanced adenoma, but they don't have Lynch syndrome. They don't have FAP or Putz-Jaeger's. And there are two family histories that we look at. And it's pertinent in that it affects the way we start our screening in these patients. One group that has familial colon cancer has a colon cancer or an advanced adenoma, greater than a centimeter, villus histology, or multiple adenomas, in a first-degree relative, mom, dad, brother, sister, who is less than age 60. Or that person may have two or more first-degree relatives regardless of age. They may have an aunt and their father that both got colon cancer in their 70s. Colorectal cancer or an advanced adenoma, also in a first-degree relative at any age, imparts some increased risk, but almost certainly not as much as in the first group. So sporadic colon cancers, familial colon cancers occur. And then there are a number of different hereditary syndromes that we're going to talk about that are much less commonly seen, but frequently, particularly with Lynch syndrome, not easily identified, not readily identified, and also great board questions. So FAP, the classic hereditary colon cancer syndrome, or familial adenomatous polyposis, occurs when, in an autosomal dominant fashion, a person inherits an APC, or adenomatous polyposis coli gene. When they inherit that gene, nearly all of these patients are going to develop colon cancer by age 40. And the phenotypic expression of that gene is the presence of numerous thousands of colon polyps throughout the entire length of the colon. Each of these is an adenoma. This is what's referred to commonly as a carpeted polyp, where polyps cover the entire surface of the colon. We start screening these patients who have the family history of the disorder, and particularly if they've been tested positive for the APC gene. We start screening these folks at age 15 to see if they're phenotypically expressing the gene that they may have inherited. Almost all do. Once these folks develop numerous colon polyps, we consider colectomy as soon as the person is physically and perhaps emotionally able to accept having a total abdominal colectomy. It's a life-altering event, and these are done very well by Mohammed Bayasi and other folks. However, these folks are never going to have completely normal bowel function after colectomy. They're going to have frequent bowel movements, abdominal discomfort in many cases. It doesn't completely eliminate the risk of colon cancer at the rectal cuff. So we work with these folks to see what's the optimal age where colectomy is appropriate. And then after colectomy, we have to importantly look for extracolonic cancers, gastric cancers, ampullary cancers in particular, desmoid tumors, osteomas. There's a whole host of extraintestinal malignancies that we need to think about. The most common hereditary cancer is hereditary non-polyposis colon cancer, or what's been referred to for years as Lynch syndrome. In this syndrome, patients develop not thousands, but 10 to 50 adenomas. These are predominantly on the right side. They're more commonly sessile serrated adenomas. These patients are much more likely to present with synchronous primaries. Usually the cancer is going to develop in the 4th decade of life. It's associated with mismatch repair genes. And extraintestinal cancers are common here as well, to include ureteral cancer, renal calyceal cancers, gastric, and endometrial. We start screening these folks every year to 2, starting at age 55. If they have a kindred. Or, importantly, many of these folks are not identified by their family history. They're identified when they develop a cancer or they've got numerous synchronous polyps. And we'll take a detailed family history. We'll have them talk to the Fisher Center. We'll have them do genetic testing to look for a mismatch repair gene. And also, you can find microsatellite instability in these polyps and cancers when they are excised. So if we have somebody that has a endoscopic finding concerning for HNPCC, we'll actually ask Dr. Izumi and his team to do mismatch repair testing, to do microsatellite instability testing on the polyps to see if Lynch may be present. The family history that we refer to in HNPCC is described as the Amsterdam Criteria, or the rule of 3, 2, 1. And what that suggests is that there should be 3 relatives with any Lynch syndrome associated cancer: colon, endometrial, small bowel, ureteral, or renal calyceal cancer. There should be at least 2 successive generations that are affected. 1 person affected should be a first-degree relative of the other 2, and 1 patient should be diagnosed before age 50. So 3 relatives with Lynch-associated cancers, 2 successive generations, and 1 first-degree relative of the other 2, and 1 patient diagnosed before age 50. The Amsterdam Criteria, out of necessity, has been modified over the years, although this is what's still most commonly used. But in the United States, in Europe, and elsewhere, large families and as such more easily accessible kindreds are not as common. So to have strict adherence to the Amsterdam criteria has become more challenging. But we still start with this when we're thinking about looking for a family history of HNPCC or Lynch. A more recently recognized disorder, MUTYH-associated colon cancer, serrated polyposis syndrome, is an autosomal recessive disorder where patients will develop anywhere from 10 to 100 polyps, generally by age 60. These can be most commonly serrated adenomas, but they can be classic adenomas as well. This is the same picture. This is, again, what serrated adenomas look like. And in these folks, we start screening them every year to two at age 25, much like someone who has a family history of Lynch syndrome or HNPCC. This, I don't think, is boards. This is a much less commonly associated disorder. Putz-Jaegers, described in part by Dr. Jaegers, who used to be a Georgetown surgeon, is an autosomal dominant disorder where a person inherits an STK11 gene that increases their risk of gastrointestinal cancers, a number of different cancers, colorectal, stomach, small bowel, and pancreas. These are associated with hyperpigmentation of the lips and buccal mucosa, as well as hamartomatous polyps. And then this is, again, this is kind of for board prep. And by the way, I'm happy for anybody who wants copies of my slides or note sets for board review later. If you want to reach out, or I'd be happy to send it to Carrie and she can disseminate it. This is a slide that's kind of a board's question focused slide. There are a number of eponymous colon cancer syndromes that are frequently discussed or asked about on the boards. Muir-Torre syndrome is a very common question, colon cancer associated with sebaceous skin cancers. Gardner syndrome is FAP that we discussed before, associated with osteomas, epidermal cyst, and desmoid tumors. Cronkite-Candida syndrome is colon cancer associated with cutaneous hyperpigmentation and onychodystrophy. And finally, Turcot syndrome, another common board question, is colon cancer associated with glioblastomas. So that is a fairly brief run through of the genetics of colon cancer. Let's talk about how these patients present. One thing that we're asking folks now is to put colon cancer perhaps higher up on the differential diagnosis when a patient comes in with a new abdominal pain or particularly a change in bowel habits. If your patient says, look, I've been regular all my life, and suddenly I'm not, I have constipation or diarrhea, think about colon cancer. Think about at least investigating a little bit more fully for it. Blood in the stool in particular, in young people, as we're going to talk about, we're asking folks to focus on more carefully. Don't assume that this is a hemorrhoidal bleed or a fissure. Particularly worrisome symptom is persistent narrowing of the stools, usually suggesting a distal partially obstructing lesion. Weight loss is a fairly nonspecific and fairly late symptom of colon cancer. Iron deficiency anemia is a common, actually about 25 minutes ago, found somebody who's referred to me for iron deficiency anemia. She had a right-sided colon cancer. We get a lot of referrals for colon cancer assessments when a patient is anemic. If a patient doesn't have iron deficiency anemia, the pretest probability of colon cancer is actually quite low. We generally don't prioritize looking for colon cancer in patients with normochromic or macrocytic anemias. But very importantly, as was the case for our index patient today, colon cancers may be asymptomatic. Polyps are in most cases, if not all cases, asymptomatic. So that's why it is so important to get these folks screened early, but also to react quickly to symptoms appropriately with a GI referral or some sort of an assessment, a hemocult or something to that extent, to better look at these folks and not just attribute blood in the stools, for instance, to colon cancer or to hemorrhoids. So how do we screen? How do we survey? There are a number of different ways that we can do this, both in non-invasive and invasive. The non-invasive is essentially stool assessments, fecal immune testing. stool fit testing along with DNA analysis, euphemistically referred to as Cologuard. And then there are a number of different anatomic assessments that are available. Colonoscopy, sigmoidoscopy, which still has a role, CT colonography, and an emerging technology, capsule colonography. So let's talk about the different options, because these are options. The one wrong thing is to not do screening. There's a number of different ways to approach it. Some ways are better than others. Some ways have a higher likelihood of appropriately identifying a cancer early in its course. But one of the tried and true, and actually still most effective ways of screening, is with fecal immunochemical testing. This is a direct measure of human hemoglobin in the stool. It's much better than hemocult testing, which was a peroxidase activity-based test. There is substantially fewer false positives because the peroxidase activity would be positive in patients who had had red meat, or who had had iron and vitamin C and other things that would make it either false positive or false negative. It's extremely inexpensive. It's something patients are much more receptive to in many cases than colonoscopy. And when performed annually, the sensitivity and specificity for the discovery of colon cancer is actually quite high. The challenge, though, is to get the patient to do this annually. For this to work, to achieve these numbers, the patient has to do the testing every single year. There is a good deal of debate. Well, when you do it every year for 10 years, isn't there a statistical likelihood you're at least going to get a false positive that's going to send you to colonoscopy? Is this a surrogate marker for testing colonoscopy's effectiveness? On some level, yes, but this is still a very effective strategy to non-invasively test patients for colon cancer and advanced adenomas. Another non-invasive way, which has gotten a lot of traction, and for some appropriate reasons, is stool fit testing and DNA analysis. And I try not to use brand names. We try to avoid using brand names, commercial names in our lectures, but just for purpose of clarity, this is Cologuard. Cologuard looks for abnormal DNA from neoplastic cells that are shed by polyps, advanced polyps, and tumors. And their goal is to look for both polyps in the sessile serrated adenoma pathway, looking for abnormal methylation, and more traditional adenomas and cancers, looking at KRAS mutations, B-actin mutations. Importantly, though, in addition to the very elegant molecular analysis, there's also a fecal immunochemical test in every Cologuard. And with this, the company publishes data that it's 92% sensitive and 87% specific for colon cancer. The cost is significant, but it's less than colonoscopy. And this needs to be performed every 3 years. And we think, not now, perhaps, but maybe in 10 years, Cologuard 4.0 might be the way we're testing large populations for cancer, and then seeing who should we then do a colonoscopy on. One of the challenges that we have right now, however, is that when the company reports a positive Cologuard assay, they won't tell us, is it the DNA that was positive or was the fecal immunochemical test? And so there is some concern on our part that these folks are selling, $600 hemocults. If 85% of the positive Cologuards were a positive fecal immunochemical test, that would certainly sway our impression of this testing, and it would affect the way we put this into our box of tools to say, what should we most appropriately use to screen patients? We've worked with the company. We reached out to the company to say, look, we're looking for greater transparency here. They have not been forthcoming, but this is a good way, perhaps a little bit better way than just fecal immunochemical testing, but perhaps not as good as we would like it to be at this point. So when somebody has a positive Cologuard, they're scared. They come to us and they want a colonoscopy. They want it soon, and rightfully so. We want to be able to give them clarity as to what the results of the positive Cologuard means. I discuss with them, this might been nothing more than a positive fecal immunochemical test. And I cite this data from Tom Imperial that was published in the initial large Cologuard studies. If you have a positive Cologuard, you have about a 4% chance of having colon cancer. So take a deep breath. You sure could have colon cancer. But it's not 100% that that's what you have. Only about 20% of these folks are going to have an advanced adenoma. Fully 75% of folks are going to have nothing or a diminutive polyp. So I try to reassure these folks while at the same time getting them a fairly expeditious exam to let them know that, yeah, this Barrett's investigation, we need to do a colonoscopy. However, all is not lost if you have a positive Cologuard. CT colonography is another good option. Very well branded as virtual colonoscopy. It's a multi-dimensional CT, which has a lot of advantages. It avoids sedation and most of the risks of colonoscopy. Although air insufflation occurs, the likelihood of perforation is extremely low. Unfortunately, it's not covered by Medicare. Its cost is comparable to a Cologuard. It's very sensitive and specific for polyps greater than a centimeter, but if you ever look at a virtual colonoscopy report, they will say this test is not designed to identify polyps less than 5 millimeters. So very frequently diminutive polyps or even large flat polyps, as I'm going to show you in a second, are missed. There are a number of extra colonic findings that are frequently noted on the CT that have to be tracked down. It is a radiation dose, but if this is going to be used, it should be ordered every 5 years. Flexible sigmoidoscopy, believe it or not, still has a role, particularly in areas where resources are not what you'd like them to be and there's not ready access to colonoscopy. It used to be the primary screening mode. It's been shown to decrease the risk of mortality from colon cancer, particularly left-sided cancer. And that's why I think some people are still appropriately screened with FlexSig. The problem is it only examines a distal quarter to a third of the colon. And with proximal colon cancers becoming far more common, this may miss a number of lesions. And I put in my slide, it may be uncomfortable. It generally is uncomfortable. Colonoscopy is the most common way that patients are screened in the United States for colon cancer. The advantage is we advance the scope all the way through. We're able to, with fairly modest sedation, perform a comfortable, thorough exam looking for traditional and sessile serrated adenomas. It's got high sensitivity and specificity for both cancers to include very diminutive polyps, 2 millimeter polyps that we find in their infancy. It's both diagnostic and therapeutic, as I'm going to show you in a second. We can remove most polyps in many early cancers. It's been demonstrated to decrease the risk of dying from colon cancer, both in the United States and abroad. And very importantly, it allows patients to have a 10-year screening interval, i.e., if you have a normal colonoscopy, you don't need to worry about colon cancer screening for a decade. Distinct disadvantages include the fact that it's not an easy prep. We've tweaked this as best we could over the years. We're using more and more Miralax, which is a very well tolerated over-the-counter preparation in split doses, divided doses to diminish the amount that's consumed at any one time. But the prep is still not easy. It's the highest cost option. It's the highest risk option of all the ways of screening. We still do have perforations on just standard screening colonoscopies. And there is a risk of a missed lesion. When we talk to a patient about perforation and bleeding and aspiration and other complications, we should be mentioning the fact that colonoscopy is not perfect and there's risk of a missed lesion. Depending upon the study that you look at, there's anywhere from 10 to 15% chance that a 1 centimeter polyp, which is a significant polyp, may be missed in the hands of an expert examiner. So it is not a perfect test, but it's a good test. And this is one of the reasons why we think that this is a preferable option amongst many. This is a sessile serrated adenoma. This is something that a virtual colonoscopy is not going to see. In a hemocult, this is not going to release any blood or a fecal immune test. And colonoscopy allows us to identify these lesions. What you see here is endoscopic mucosal resection, where we're injecting methylene blue and saline into the polyp to lift it up off the colonic wall. It defines the border of the polyp so that we know where it starts and where it stops. And we can then go ahead and remove the polyp in its entirety using cautery. And now the cautery from our snare is much farther away from the outer wall of the colon, the serosa. So there's much less likelihood of perforation. And you can see we're getting the entire lesion off with a good mucosal margin. And at the end, we want to see the submucosa, and we retrieve the polyp. That's one of the great, I think, uses of colonoscopy for identifying sessile serrated polyps. We also have larger lesions, which, and my apologies, I have de-identified this slide twice, and it appears it re-identified itself. Let me quickly go through. This is a large pedunculated polyp. This is much like our index gentleman's case, where there is a large polyp on a stalk. We inject the base of the polyp with epinephrine because there's also a very large artery in these stalks. We put a snare loop around it, which is essentially a proline suture to grasp and occlude the artery within the stalk. And as you can see us close down on this, this will start to get ischemic. So we put our loop around it. And then we put our snare around. And we cauterize through, trying to get a good stalk of normal tissue, normal colon tissue, and remove the lesion in its entirety. Keep our fingers crossed that we're not about to see a large arterial pumper here. We use cautery as we cut through this, which cauterizes the vessel in addition to the epi, and then we put some clips on the site. So there's a lot of different ways that we can screen for colon cancer, and there frankly is not uniform agreement on what's the best method of screening. The multi-society task force recommendation that I'm going to show you suggests colonoscopy or FIT testing as the primary modalities. The NCCN and the ACG say colonoscopy is preferred. The U.S. Preventive Health Services Task Force has a whole host of different options as well, all of which are treated essentially equally. But the Multi-Society Task Force, which is a group of the primary gastroenterology societies, colorectal surgeons, GI Nursing Society, ranked the choices essentially in order of the greatest likelihood of decreasing the likelihood of death from colon cancer. Tier 1 is a colonoscopy every 10 years, or a FIT test annually. These are roughly equal in terms of their ability to decrease the mortality of colon cancer, although there's a little bit of an edge to colonoscopy. Tier 2 is FIT DNA or Cologuard every 3 years, virtual colonoscopy every 5 years, or a FlexSig every 5 to 10. Tier 3, and I'm not going to discuss it very much because it's an emerging technology. You folks have maybe seen us use pill cams or capsule endoscopy to look at the small bowel. This has also been used to look at the colon. It's helpful but not perfect. The pill tends to tumble in the colon because of the width of the colon. So there is some greater risk of missing things, so I won't talk about it in great detail. But again, for board preparation purposes, this would be a helpful slide to know that these are tier 1, these are tier 2, and if you're going to use FIT DNA, it's every 3 years. Virtual colonoscopy every 5 years. So that's how we screen. Who should we screen? And when we look at patients who are at average risk, patients who have no family history of colon cancer, no symptoms, no prior polyps and no inflammatory bowel disease, those folks should start regular screening at age 45. This is new. This is new in the last 18 months. It's new in part as a result of a significant increase in the incidence of colon cancer in young patients. And importantly, the insurers in this region have begun to pay for colonoscopy at age 45. That's been a rate-limiting step nationally. Locally, Aetna and Blue Cross Blue Shield of Delmarva are paying at age 45, and others are now following those. And we should be screening folks who are in good health, folks that are going to at least live another 10 years. So when we start at age 45, we should continue screening through to age 75 in those folks, again, who are in good health, expected to live another 10 years. If somebody is 64 and has, advanced heart disease, advanced COPD, if the comorbidity is going to take their life well before colon cancer should, colonoscopy for screening purposes is probably not appropriate. To investigate symptoms, we would still likely perform it, but for pure screening, we likely would not. Once you hit age 75, what do? This is a really challenging question that we're facing nationally. And the U.S. Preventative Health Service and the Multi-Society Task Force have both said with very similar language, patients aged 76 through 85 should decide with their healthcare provider whether they should continue to get screened. The risk of a sedation reaction begins to rise appreciably. However, not every 78-year-old is as healthy as another 78-year-old. There are some folks who I think I do a lot of good for if I do an age 78, 79, 80-year-old colonoscopy. If I think they're going to live, if they're a very healthy 80, I can do two things. I can decrease their polyp burden. I can take off the 3 or 4 small polyps and tell them, perhaps you could have developed colon cancer, but the likelihood of doing so now is so low, there's not really an appropriate reason to screen. Or if it's a normal exam, I can tell you again, go live your life. Don't worry about something besides colon cancer. So I think some of these folks are appropriate for screening, but this should be done on an individualized basis. Once a person hits 85, the likelihood of their living another 10 years begins to substantially drop. And in that instance, colon cancer screening is no longer appropriate. Again, symptom investigation very well may be. Colonoscopy may be appropriate in an 87-year-old who has iron deficiency. Actually, the person I referred to just a little while ago who wound up having colon cancer, we investigated her for symptoms. We would not have done so for screening purposes alone. So that's for average risk patients. How about if you have a family history of colon cancer? And again, I'm going to go back to the slide I presented earlier. There's 2 colon cancer family histories that we worry about, in addition to HNPCC, or FAP, which is a completely different scenario. If you have a family history of colon cancer or an advanced adenoma in a first-degree relative, mom, dad, brother, sister, less than age 60 years old, or if you have 2 or more first-degree relatives of any age, you should have a colonoscopy at age 40 or 10 years younger than the person was when they got their cancer. So if your mom got colon cancer, she was 48, you should start at age 38. And you should consider repeating the colonoscopy every 5 years, regardless of findings. If you have colon cancer or an advanced adenoma, a large polyp that had a good chance of becoming cancer in a first-degree relative of any age, if your dad had colon cancer at age 78, start screening at age 40. And there is less need in all likelihood to continue an every 5-year exam in that instance. But having an index baseline screening colonoscopy earlier than we otherwise would, I think is a good idea and is borne out by the literature. So that's who we screen, that's how we screen. And then we should talk about how we survey patients once they've had a colonoscopy. And we do this based on the number of adenomas, the type, the histology of the adenoma, and the size of the adenoma. Here's an almost certain board question because it's got a lot of clinical and financial implications, public health implications. If a patient who has no symptoms, has no family history of colon cancer, has no personal history of inflammatory bowel disease, and they come in and they have a normal colonoscopy, and the prep is good, if you can see well, they should not have a colonoscopy for 10 years. And I would go as far as to say, I'm not saying they don't need to. I'm saying they should not have a colonoscopy for 10 years because you've done a very good risk stratification assessment of that patient based on very strong data, high quality evidence. They should not have a colonoscopy for 10 years. And that's because the data is so strong and there are so many implications. I think you can largely count on that as a board question. If a person has 1 to 2 small polyps, if they're less than 10 millimeters, 7 to 10 years, and most of us are saying 7, the more polyps you have, once you hit 3 adenomas, or if the polyp is greater than 10 millimeters, or if there's villus histology, those folks generally will have a 3-year exam. And again, that's an important thing to remember. Greater than 1 centimeter, villus histology in the polyp, or more, 3 or more, that's a person that needs a 3-year exam. And then if a person has 10 or more, it's a year, and you ought to be thinking about a hereditary cancer syndrome. This slide that I show you, which again is a good thing to be able to refer to if you want to print the slides for a handout, is this slide is for adenoma surveillance. If somebody has a sessile serrated adenoma, the surveillance guidelines are a little bit different in that, again, if it's a normal, or if these are completely, if the polyps are truly hyperplastic and they're all in the sigmoid or rectum, those distal hyperplastic polyps have no potential to turn into cancer. They're like a person who had a normal exam, they get 10 years. If, however, you have 1 or 2 sessile serrated polyps, it's 5 years, 3 to 4, it's 3 to 5. But again, if you have more than 5, if it's greater than 1 centimeter, if there's dysplasia or villus histology, it's 3 years. When we talk about these surveillance intervals and we talk about lengthening the interval, this is all predicated on having a very high quality colonoscopy. This is something that we really focus on GI. We want to make sure that the bowel prep is adequate so that we can see. We want to take our time, do a careful assessment, and we want to look at what our adenoma detection rate is. What's the likelihood that a gastroenterologist is going to find a precancerous polyp? How well does that doctor look for polyps? And how well can we assess that this person really has had a good, thorough exam and can go a full 10 years if need be? You're going to see this in most of our colonoscopy reports. This is the Boston Bowel Prep score. We formally evaluate this and document it in every procedure that we perform so that we can say, if I can't see, I can't do a good job for the patient. So I want to be able to say, yes, I was able to thoroughly look through the colon. Each segment, the right colon, transverse colon, left colon, gets a score of 0 to 3. And we have this displayed for the physician while they're doing the report to give them examples. And if a person has a 2 or a 3 in all of the primary segments, that would suffice as an adequate exam. So we can say, okay, we can have the person come back based on whatever the guidelines would say. They don't have to come back early because the prep wasn't good. If the prep was not adequate, if your patient comes back to you and they had a 1 or it's described as inadequate, they likely need an earlier exam than they otherwise would have. And most of us would say within the year. In addition to scoring how well the prep is, we want to score ourselves on how careful and how long did we take to inspect the colon. Did we do a gradual, thorough job? Or in some centers, we're doing 18, 20 cases a day, and we're doing them as quickly as we can, and we're not perhaps doing them as thoroughly as we would like. At Georgetown, we score ourselves. This is the internal withdrawal time data from all of the primary physicians in the Department of Gastroenterology over the last 6 months or so, 11 months or so. And the goal, the benchmark that we set for ourselves is at least a 6-minute withdrawal time. So on average, our group is well above that. And we want to kind of note in our mind, we actually put in the report, if it was less than 6 minutes for a withdrawal time, why? The last thing that we look at, and what we really focus on, perhaps because it's the best validated quality measure in gastroenterology, is what's called the adenoma detection rate. What is the likelihood that a physician who is doing a screening colonoscopy, asymptomatic patient, no history of colon polyps, no history of IBD, what is the likelihood that they're going to find an adenomatous polyp? The benchmark nationally has been set that a physician should find an adenomatous polyp in 30% of male patients and 20% of female patients based on the prevalence of adenomas in those two genders. Females are relatively protected, although not completely, against adenomas in comparison to men. And as such, we should be finding polyps 30% of the time in men and 20% of the time in women. And if a physician's not doing that over a long period of time with a large denominator assessment, then perhaps that physician needs to look at themselves to say, why am I not finding these polyps? Do I need to have a longer withdrawal time? Do I need to be more careful? Do I need to be retrained in looking for sessile serrated adenomas? Just like the last slide I showed you, this is the data from the primary gastroenterologist at Georgetown. We're well above the national benchmarks for men and for women patients for two reasons. One, I think we do a real good job here of looking for polyps. But I think as importantly, these benchmarks are set too low. We now have high-def scopes, high-def monitors, and when you're doing everything you should do to find polyps, these numbers, the 30%, 20% are way too low. The prevalence of polyps in men and women is actually much, much higher. So when we're looking for polyps, going back to our index case, what is the criteria for an R0 endoscopic resection? When as a gastroenterologist can I feel like, okay, I cured your cancer by taking out your malignant polyp? Going back to that initial gentleman's slide, you want to have an intramucosal cancer that is well or moderately differentiated. The tumor extends into the lamina propria or muscularis mucosa, but no more than 1,000 microns into the submucosa. There should be no lymphovascular invasion, and both the deep and mucosal margins should be uninvolved by invasive cancer or dysplasia. And then finally, does the endoscopist feel like they got the whole lesion? We will frequently have a subjective sense that, yeah, we got it all, or we didn't. And if we don't feel like we got the entire lesion subjectively, even though we may have met all these criteria, we will likely refer the person to surgery. When we make that referral, we want to send patients to Dr. Biasi who are appropriately staged. If somebody has widely metastatic disease in the liver, it may not be appropriate, it may be inappropriate to do a colonic resection. So in general, patients should have a CT of the chest, abdomen, and pelvis. Chest is particularly germane in patients with rectal cancer. It may not be as helpful in patients with colon cancer, with a more proximal cancer, but in rectal, a CT of the chest is appropriate. A preoperative CEA for later measurement is helpful. PET scan generally does not add to the preoperative staging in addition to the CT of the chest, abdomen, and pelvis, unless there is an indeterminate lesion, indeterminate hepatic lesion, or lymphadenopathy that may be seen on exam. So otherwise, a PET is not as helpful. If a patient has a rectal cancer, a pelvic MRI or endorectal ultrasound to assess the T stage, the depth of invasion is important. And then obviously, first there's the clinical staging, and then there's the pathologic staging after the resection is performed. So this is an extremely busy slide. This is the Tnm staging of colorectal cancer, which I present to you to demonstrate what a busy, what a very specific exercise it is to stage colorectal cancer. And based on this, treatment decisions will be made. In general, a stage 0 is an endoscopically removed polyp. A stage 1 reaches but does not invade through the muscularis. Stage 2 goes into the muscularis but not through the serosa and does not have lymph node involvement. Stage 3 is when there is lymph node involvement, or if it's locally invasive. And stage 4 is when it's spread to other organs, obviously. And in general, stage is strongly associated with survival. If you have a stage 1 or 2 colon or rectal cancer, survival nationally is excellent. And this is why we want to screen folks and identify these cancers as early as it's possible. Even stage 3 disease, nodal disease, has a high likelihood of cure, high likelihood of 5-year survival. Stage 4, obviously not as much. And actually that should say total survival. The reason that we harp on screening so much is that screening, we think, along with better surgical techniques and also very effective adjuvant chemotherapy, has significantly decreased the likelihood of dying of colon cancer in both men and women, starting right around age 85. Wide population-based colon cancer screening started around this time. Those of you are old enough to remember, President Reagan was diagnosed with colon cancer late in his first term. And at that time, colon cancer screening, along with colonoscopy, began to be widely available and much, much safer. And we have had a substantial improvement in the likelihood of dying of colon cancer nationally since that time. Unfortunately, we had a setback, what I think is a temporary setback, but a setback nonetheless, associated with COVID. This is data from the Lancet. This is from the National Health Service in England, where they have found, in comparison to 2019, they had a substantial decrease in the number of referrals to colorectal surgery and oncologists for colon cancer during the pandemic as a result of decreased screening. They've had a reduction in the number of surgical procedures as a result of an identification of colon cancer in the same time frame. And notably, and I think we're seeing this locally as well, we're getting back to where we were, but we're not there yet. We had a real uptick in screening at the end of the year. People had gotten through their initial fear of COVID. They had delayed things that perhaps they had not wanted to, and we had a huge rush toward the end of the year. We're having another little bit of a downturn now, and a downtick, as patients are saying, you know what, I'm going to get screened, or I'm going to evaluate the blood and the stools, but I'm going to wait for my vaccine. I'm going to get vaccinated, and then I'm going to come for screening. Because of this, there's one paper from Hong Kong where they estimate, using a modeling analysis, that there's going to be a 5% upstaging of gastric cancers and a 6% upstaging of colon cancers in their population as a result of the hiatus in screening or hiatus in diagnosing symptoms. So unfortunately, I think that this is going to be with us for a little while, but our hope is that we're again, these curves are going to once again meet. Just a couple of slides left, and I want to leave you with these slides for a reason. The curve that I showed you before, suggesting a significant decrease in the likelihood of dying of colon cancer, was in all races, all ages, and this continued down. But unfortunately, in about 2005, there has been a substantial uptick, a meaningful uptick in the incidence of colon cancer and colon cancer mortality in adults aged 20 to 54. We are seeing this nationally, we are seeing this locally. And as such, the likelihood of, the age of first screening was dropped from age 50 to age 45. That's good. However, the people that we're seeing, the young people that we are seeing diagnosed with colon cancer, are in their late 20s and 30s and early 40s. So the age 45 is not going to help them. We can't start screening everybody at age 25. That's impractical. But the message I want to leave you with is that think about colon cancer, put it into the differential diagnosis in a younger patient that you're seeing, particularly if they have blood in the stools. Don't just suggest that it's hemorrhoids or anal fissure, which statistically it still probably is. But think about having these folks evaluated for blood in the stools, abdominal pain, change in bowel habits, and narrowing. Particularly if there's blood in the stool, we are all pressed for time in our clinics, but do a rectal exam. Try to do a digital rectal exam. Very cost effective, very effective way of screening for rectal cancer. And also confirming or dismissing the possibility of hemorrhoids. There is still discussion that we may change our screening guidelines further and reduce the age of screening further, but I think that this is unlikely. I think going from 50 to age 45 was an easy one. I think going much lower than that is going to be a harder sell. And as such, please react to symptoms in younger people. These folks have a higher mortality because they have a much greater delay in diagnosis than older patients who have a differential diagnosis holding colon cancer higher in rank. So please think about it in these young folks and send them to us or do further investigation. Bottom line is it's your patootie. No matter what you call it and how you check it, have it checked.